During the current pandemic, telepsychiatry enabled provision of traditional treatments with modern approaches. Implications of telepsychiatry during COVID-19 are important and may have a long-term impact on the future of mental health care as well as the future of e-mental health itself. Since the beginning of the pandemic, the researchers have described its tremendous impact on mental health of confirmed or suspected cases of COVID-19, health professionals, previously or currently mentally ill individuals, and finally on the general population. The initial consequence of the pandemic was limited access to care for all except severely ill patients. It was logically due to high risk of being contaminated. For a few colleagues who already practiced telepsychiatry, the solution for increasing the access was obvious: the use of standardized telepsychiatry services. Unfortunately, the mental health care systems worldwide were not prepared for it. So we improvised in order to help our patients. Very soon after the first shock, the governments worldwide have waived potential penalties against healthcare providers that serve patients through everyday communication technologies during the pandemic. Telephone consultations, email correspondence, and SMS communication were recommended as the tools for increasing access to care. Further, widely available communication apps such as FaceTime, WhatsApp, Viber, or Skype, each of them not fulfilling common requirements related to data and patient safety and security. At the same time, professional, safe and secure software compatible with standalone systems already installed in most psychiatric hospitals was released for free under COVID-19 period. But neither professionals nor patients used them. Regulatory changes made ad hoc certainly enabled increased access to care for the patients in isolation. Best documented are federal policy changes made in USA and followed by many countries worldwide. The first one is removal of the originating site rule, so physicians can be paid for remote consultations wherever the patient is, including in the patient's own home. The second important change is the near doubling of the number of services covered by health insurance companies, including emergency department visits, initial nursing facility visits and discharges, and therapy services. Among other temporary policy changes during the pandemic, we may mention some which allow providers to practice remote care even across state lines in USA. In a few places in Europe, insurance companies covered telepsychiatry sessions even for patients outside their home country. To deliver care to both established but also to new patients, and finally to get paid for the services whether they are video and or audio only, as if they were provided in person. The impacts of mentioned temporary changes were tremendous. Increased access to care in time of social isolation, limiting the spread of the virus by keeping people at home, familiarity with the new concept called home telepsychiatry that neither the patients or vast majority of psychiatrists were familiar with before the pandemic. changing of daily routines and workforce utilization of telepsychiatry across the healthcare delivery landscape during the COVID-19. And finally, continuity in care provision, which is one of main advantages of telepsychiatry in general, but extraordinarily important in time of isolation and lockdowns worldwide. The United States of America is the country where the majority of the world's telepsychiatrists are located and practice telepsychiatry before the pandemic. The study, which explored psychiatrists' use of telehealth before and during the pandemic, was launched by the American Psychiatric Association in April, a few months after the COVID-19 outbreak. Prior to the pandemic, most psychiatrists were not using telepsychiatry at all. 64% responded seeing 0% of their patient caseload via telehealth. 2 months into the pandemic, this number shifted dramatically to 85% of respondents seeing more than 75%, or some places even all of their patients via telepsychiatry. So, what are the main lessons learned during the pandemic? Firstly, the establishment of remote consultations does not require an unprecedented effort, but primarily the removal of regulatory barriers to achieve better access to care, reduce no-show rates, and increase the level of patient satisfaction. So what had to be done to sustain this momentum? Well, to ensure that patients do not lose remote access after the pandemic and to prepare for future unprecedented events, we are considering certain recommendations that may be addressed on 3 different sides: policymakers, producers of video equipment, and professionals, providers of telepsychiatry. To policymakers, we may recommend following: to permanently remove geographic restrictions for remote mental health care provision and allow the patients to be seen in the privacy of their own home. To continue to pay remote services on par with in-person visits. To include not only individual but also remote group psychotherapy into the list of services covered by health insurance. To fund research to understand the successes, challenges, barriers, innovations, safety, training needs, and workforce utilization of telehealth across the healthcare delivery landscape during the COVID-19. And finally, to start the work of creating uniform licensing rules, first regional and then global, that may enable international telepsychiatry utilization and collaboration across national borders. Video equipment producers must improve interoperability and intercompatibility of the video tools. It will enable increased collaboration across boundaries of each specific brand. Example, WebEx may be compatible with life-size and other safe and secure video apps and softwares, etc. Currently, non-safe but widely adopted applications such as Skype, Zoom, Viber, FaceTime, etc. must improve its data and patient safety properties. It is important in order to use it in home telepsychiatry services in the future, regardless potential pandemics, disasters, or other unprecedented events. The urgent need for clinical training and skills building around telepsychiatry, as well as other e-mental health applications such as mobile apps, artificial intelligence, virtual reality, etc., will determine the influence that psychiatry can have in addressing the mental health sequelae of the current pandemic. Offering digital literacy and telepsychiatry competencies training can ensure that all clinicians have the knowledge and skills necessary to work at full capacity through new digital media. In the future, we may hope to quickly initiate the regulatory changes required for the globalization of telepsychiatry, so that colleagues around the world can exchange expertise and knowledge, as well as assess and treat patients across national borders. Globalization of telepsychiatry is one of important preconditions for reducing the disparity in access to care and improving international collaboration. We may hope to maintain the current momentum after the COVID-19 and continue to use and further develop telepsychiatry along with a number of e-mental health applications in our daily practice. Previously outlined recommendations to all involved in the digitalization of mental health care, supported and implemented by highly competent professionals, are essential to modernize the delivery of care and prepare for future unprecedented events. Thank you for your attention.